I presented at these American Heart Association scientific sessions the AF Alert trial. This was a study focused on improving utilization of anticoagulation in high-risk atrial fibrillation patients for the purposes of preventing stroke. And so what we did is actually look at a computerized decision support tool, an EPIC electronic health records system best practice advisory, to notify providers that the patient that they are taking care of is at increased risk of stroke because of atrial fibrillation, and if the patient wasn't receiving anticoagulation, that they should be. And we studied the impact of this alert in the form of a randomized controlled trial. So the way the BPA actually worked was it first looked at hospitalized patients who had an admitting diagnosis of atrial fibrillation. Then it's actually able to calculate their stroke risk score. We use the CHADS-VAS score, which is the currently the most accepted risk score. It was able to calculate that. If the score was 1 or higher based on the evidence-based clinical practice guidelines that we used at the time of the study, then it looked to see if there were any orders for anticoagulation written for the patient. And if there weren't, then patients were randomized to their provider receiving an alert or not an alert. And it just depended on the attending physician of record's ID number. If it were odd or even, then they would be assigned. And the alert that went to the active group notified the provider about the patient's risk for stroke in atrial fibrillation and the fact that there wasn't any antithrombotic therapy being prescribed. And then the provider was given the option of 3 different possible selections. One is to write for anticoagulation based on an order template that we devised, which included direct oral anticoagulants and warfarin. 2, they could read about evidence-based clinical practice guideline recommendations for stroke prevention and atrial fibrillation. Or 3, they could keep going with their admission orders, but then they had to provide a reason why they weren't giving anticoagulation. And they had a number of choices they could select. And what we found in, we studied 458 patients, what we found was that the alert increased prescription of anticoagulation for patients during the hospitalization, at the time of discharge, and also at 90 days. So there was sort of a persistence of the effect of the alert. As a secondary outcome, we looked at a composite endpoint of stroke, TIA, myocardial infarction, and all-cause mortality, and actually found in the alert group that there was a reduction in this composite endpoint of major cardiovascular events. And when we looked more closely, it was largely due to a reduction in the cumulative risk of MI and stroke. So I think the immediate practical implication of this study is that more research into computerized decision support for stroke prevention and atrial fibrillation should be conducted. We have planned a second study to be performed in outpatients, and that'll be very helpful to see if we notice the same impact on clinical events and prescriptions of anticoagulation, because that would really support the fact that the alert is having this sort of an effect on the care of patients. So I think that more research is warranted, specifically looking at clinical outcomes, and we plan to participate in that type of research. But I think other centers using other electronic health records systems should also look at the same. I think that's the immediate take-home message. I think computerized decision support's gaining quite a bit of traction as mobile health technologies and health information technology-based techniques for improving care are gaining a lot of popularity. I think computerized decision support's benefiting from that. I think there are still a lot of questions about how CDS actually works. We know it can change physician behavior, but it may have effects that extend beyond that. The intended alert, like in our study, for writing prescription for anticoagulation seemed to have an an effect on prescribers following the guidelines more closely, but it also seemed to have effects on myocardial infarction and stroke, which may be out of proportion to what we saw in the prescriptions of anticoagulation. So there may be other effects of these alerts. They may function as just an overall alert to the provider that their patients at increased cardiovascular risk in general. I think we need to do a lot more research into CDS to find out exactly how they change physician behavior. Yeah, I was very excited to be part of a panel of several late-breaking clinical trial presenters who had done work with either decision support or other types of health information technology to improve the quality of care. A number of them had very complex, beautiful approaches to improving care, where they weren't just notifying providers, but they were interacting with patients and making patients part of the team for preventing cardiovascular disease. And I will definitely take home a lot of the lessons learned from those studies when I think about my studies in the future.